Hello, everyone. I'm Colette Inaba from the University of California, Irvine. I'd like to thank the SAGES Committee for inviting me to come share our research today on laparoscopic versus open resection of gastrointestinal stromal tumors. This one. None of us have anything to disclose. So gastrointestinal stromal tumors, or GIST, is a relatively rare disease of the GI tract and occurs most commonly in the stomach and the small intestine, which in total comprise about 90% of cases. Because GIST grows in an expansive rather than an invasive fashion, GIST resection just requires negative margins. Also, because lymph node metastases are rare, lymphadenectomy is not required for routine GIST resection. These features make GIST particularly amenable to laparoscopic surgery. However, there's concern that laparoscopic manipulation of the GIST tumor may rupture the pseudocapsule, and rupture would increase the risk of recurrence. At the same time, we all know that there's a lot of benefits to laparoscopy over open surgery. So there needs to be a balance between perioperative outcomes and as well as long-term oncologic outcomes. So there's been great interest in comparing these two approaches for GIST resection. In just the past 5 years, there have been over a dozen meta-analyses on small institutional studies. And here I have the 4 most recent ones just published since last year. And they all pretty much say the same thing. That is, there's no significant difference between survival for a laparoscopic versus open approach. And some studies have even found improved survival after a laparoscopic approach. However, these studies are based on collection of small institutional series, and for the most part, they don't adjust for tumor size or stage of disease. So this begs the question, is there selection bias? Are we seeing any confounding from surgeons preferentially using laparoscopy for smaller tumors or tumors with a lower stage of disease? So our objective for this study was to use a national database to compare laparoscopic versus open resection for GIST after adjusting for tumor size and stage of disease. To do this, we use the National Cancer Database, which is a longitudinal database comprising data from over 1,500 centers nationwide that have been accredited by the ACS Commission of Cancer. We examined all adult patients with non-metastatic GIST of the small intestine and the stomach who underwent either laparoscopic or open resection, and then compared the stratified data, so stratified by pathologic stage. We compared survival outcomes based on surgical approach. And here are the demographics and comorbidity scores for just under 5,100 GIST resections stratified by stage of disease. I'm not going to spend a lot of time on this because all these variables were adjusted for in our final analysis. Here are the results for tumor pathology and our outcomes of interest. The main things I wanted to point out on this slide was that you can see that indeed resections that occurred open were larger in size, the tumors were larger in size, and this was statistically significantly different on univariate analysis across all 3 stages. In addition, there was no significant difference in the ability to attain a negative margins or an R0 resection for laparoscopic versus open resection. Mortality, readmission, and length of stay were all variables that we use in our multivariate analysis for which we controlled for patient demographics, comorbidity score, tumor size, and tumor location, meaning either the stomach or the small intestine. And here are the results of that multivariate logistic regression. We could not perform an adjusted analysis for 30-day mortality because the model became unstable, but for 90-day mortality, we found no statistically significant difference between laparoscopic versus open approach, even after adjustment. Likewise, no significant difference for 30-day readmission, but for length of stay, we found a 24 to 36% decreased length of stay for laparoscopic approach compared to open, even after adjustment. Here are the crude Kaplan-Meier survival curves for long-term survival for stage 1, and the difference was statistically significant for decreased, or I guess improved survival for a laparoscopic approach. This is for stage 2, and again, improved overall survival long-term for a laparoscopic approach. and stage 3 was no statistical difference. Now, Kaplan-Meier curves are not adjusted, so we have here an adjusted Cox proportional hazard model where we could take a look at each of these different variables and find how they affect the hazard of death when adjusted for all the other variables are held constant. So we found that increased age, black race, higher comorbidity score, and small intestinal versus gastric location was associated with increased risk of mortality. Female gender was associated with decreased risk. And then finally, laparoscopic approach was associated with a 20% decreased hazard of death, but with a p-value of 0.06, it did not meet the 5% threshold for statistical significance. Limitations of the study, it is a retrospective database study, so there is potential for bias from missing data, coding errors, and also the NCDB doesn't include variables that would have been nice to be able to adjust for, such as tumor rupture or mitotic rate specifically for GIST. That said, this is the largest study to date comparing surgical survival outcomes for laparoscopic versus open resection of gastric and small intestinal GIST. And importantly, we did adjust for multiple variables, including patient demographics, comorbidity score, tumor size, and stage of disease. In conclusion, our findings suggest that laparoscopy is a viable technique for both gastric and small intestinal non-metastatic GIST resection. Laparoscopy is associated with decreased postoperative length of stay and no difference in short-term survival. And in addition, there's possibly decreased risk for long-term mortality with laparoscopy, at least for early-stage disease. Further research is needed to better risk stratify patients for laparoscopic versus open resection, particularly for small intestinal GIST, as well as for advanced stages of disease. And with that, I'll take any questions.
Thank you.